Hi, this is Dr. Diane Gayhart, and this is my lecture on cognitive behavioral therapy and counseling. It is an introductory one that kind of covers the basics because this is a broad area, but it is designed to go with my textbooks, case documentation in counseling and psychotherapy, as well as theory and treatment planning in counseling and psychotherapy, which go into much more depth than I can do in this one online video. And there are also many other free resources you can find at masteringcompetencies.com. So, giving a lay of the land of cognitive behavioral, or CBT as most people refer to it in the field, is not easy actually, because there are different versions of how it evolved or what's what. So I'm going to primarily, the behavioralists have one way of kind of defining the different phases, and the cognitive folks have a different way of doing it. But basically, CBT refers to this very broad range of therapeutic models that are grounded on some very basic behavioral concepts as well as cognitive concepts. And so originally these, as you may be obvious, maybe not, they originally evolved as separate approaches, but most people will use these together. Not always, but and also depending on the problem, they might use more behavioral versus cognitive. For example, phobias and such often respond very well to a more behavioral than cognitive types of approaches. So the behavioral approaches evolved out of research such as classical conditioning. Those are Pavlov's dogs, and you ring a bell, a dog salivates by pairing different stimuli. Operant conditioning, which are the Skinner boxes, so you slowly reinforce steps towards a desired behavior to encourage to train or teach or learn a new behavior. And also at social learning theory is also under the umbrella of behavioral approaches, how we, watch others and learn behavior that way. So that's one of the early schools, and they began in labs, kind of psychology labs, and the principles they learned from those laboratory experiments got translated into a therapeutic approach. And then similarly, the cognitive approaches evolved out of cognitive theories in psychology, and then it evolved into a therapeutic model early pioneers in this area like Aaron Beck used a purely cognitive model. And like I said, though, most people today do a blend of these two. The cognitive behavioral, it's probably the most frequently cited therapy model. It is favored often by insurance companies and HMOs because it follows a medical model. It's it has very strong evidence base to it because these approaches actually, emerged from a modern scientific method, and so it's very natural and congruent to be doing kind of evidence-based studies on these approaches, and they lend themselves well to, they're very easy to study compared to something like existential therapy that is dealing with much more philosophical concepts that are just hard to operationalize in the beginning, where behavioral therapy emerged directly out of psychological experiments, so they naturally translate to that environment. And they also just make sense. They make logical sense. And so I think that's also why a lot of people use this. That said, I don't think a lot of people do CBT all that well. And so even though many people will cite it, they're referring to mostly doing psychoeducation, where I think, especially when you start working with cognitive therapy, delivering that well and doing that well, I think takes a lot of skill, and it's more subtle than maybe the intervention of psychoeducation. So I encourage you, if you are interested in this approach, to really develop some of the finer skills, because there is an art to it, I think, when it's done particularly well. And it's also useful to mention, I think I go into this in the book, but I'm not going to do a whole lot on this in this particular online lecture, although I have other online lectures on mindfulness. It's a particular area of interest and expertise of mine. But there's a whole new wave of mindfulness-informed and mindfulness-based therapies. And within the behavioral tradition, they call it the third wave of behavioralism. I don't know if the more CBT people call it that. But what's interesting about mindfulness is that it involves, especially the practice of mindfulness involves watching your breath while quieting the mind. And learning to observe what is going on without trying to change this. And this is really countercultural to, if you're going to use the behavioral world, the first two waves of behavioralism, where it's, identify the problem behavior, and fix it, identify the irrational thought and correct it. So CBT has always been very corrective. And mindfulness is the opposite of that. It's paradoxical in some ways, in that by simply observing your mind and by accepting what is, your relationship to it changes, and so your experience around it changes. So it's got this paradoxical element of change to it, but mindfulness is being broadly used in conjunction with CBT therapies nowadays and other therapies. And it did actually emerge out of behavioral medicine in a hospital setting, working with clients who had chronic pain with John Kabat-Zinn's mindfulness-based stress reduction at the University of Massachusetts. So this is kind of the third wave, and it's often added or complements other CBT approaches. Again, it's very easily studied, so the evidence base for it is rapidly emerging, unlike really anything I think I've ever seen in my career in terms of watching a particular approach be studied. But again, it lends itself so nicely to it because it's a very concrete intervention, and so it's relatively easy to measure the outcomes of those interventions. So this is, and then there are multiple forms of CBT that I do go into much more detail in the book, but again, it's a very broad area, and so I encourage you to do more reading. You can start with one of my texts, but there are many, there's a lot of reading to be done here. So this is just an introductory overview of the world of CBT. And so from here forward, I'll be talking about, the more traditional, if you want to call it the first and second waves of, behavioral techniques, cognitive, and then kind of the combined CBTs. In a nutshell, the least you need to know. So as the name implies, and as I've already mentioned, CBT combines behavioral techniques and interventions with cognitive. So the behavioral piece of CBT focuses on analyzing how the symptoms are being reinforced in the person's day-to-day life, and then you identify ways to either shape or reinforce desired behaviors instead. And so in the case of, working with anxieties and phobias, you would look at, what's reinforcing, the anxiety or phobia, and then you would identify what kind of strategies can we use to address this. You could do something, and we'll talk about some of those, graduated exposure. So, a little bit of exposure at a time to whatever the feared object is, a spider or a snake or whatever that might be. So those are the behavioral, and there's a wide range of behavioral interventions. On the cognitive side, what cognitive elements of the approach are doing is they're looking at what you might call distorted or dysfunctional thinking or irrational thinking, and look at how that is creating whatever the problematic symptom is. It might be depression, it might be anxiety, it might be a phobia, and so, or even an eating disorder or relationship problem, whatever it is. So you would analyze where is the distorted thinking or problematic thinking that is related to the symptom. So maybe with depression, you might have someone who just went through a breakup and they feel like their life is over. So it's probably an over-exaggeration of the situation, and so you would look at that, their beliefs that are creating the depression due to the breakup. So that's the basis of it. In terms of the role of the counselors, compared to, for example, many other therapists like psychodynamic or humanistic or existential, they have a much more educational and expert position that CBT therapists typically take in relationship to their clients. And so that is different within the different schools in comparison to other schools. And so there is a little bit more of an expertise and a hierarchy and a sense of being educational, kind of helping to fix the problem for their client, rather than simply, for example, in the humanistic approach, the therapist is creating a particular process, and through this process, the client, self-actualizes. And so the focus is really on just facilitating a process. It's not that the therapist necessarily has this expertise that they're teaching to the client. So it is a particular type of relationship role. As you may imagine, in the beginning, since many of these theories, are developed out of a laboratory culture, the counselors and therapists tended to have a very detached attitude with clients, or relationship with clients. And over the years, there has been a greater introduction of warmth and empathy into the therapeutic relationship. And that's more typical of contemporary 21st century CBT. So now I want to highlight the juice, or there are many significant contributions, but what I think is one of the more significant contributions to the field by CBT therapists. So I'm going to talk about Ellis's ABC theory of change, and it is a cognitive model, but it also there's a version of this in all the different schools, but the basic idea here is that most of us, have a life experience, which they're calling an activating event, and then there's a consequence. We experience a mood or a behavior, and normally what therapists are looking at, or CBT therapist is analyzing, is, we come in, my girlfriend broke up with me, and then the consequences, I'm sad, and I'm angry, and I'm hurt. So, and that's often when you're in it and you're experiencing it, that's what it feels like. She broke up with me, and that's why I'm depressed. What we don't realize, and what is not, I would say, natural for most of us at least, is that in between, what mediates that is a belief. And that belief we can have conscious control over, and we can change our the undesirable consequences, like sadness or, bad behavior on our part, whatever it might be, by changing the belief. And this is often just put out there, the ABC theory, and it's when this sinks in, and you begin to see that all of your internal world can be navigated this way, this is a really profound insight. And it can be a difficult one at first. I think most of us don't want to hear in the beginning that, oh, no, she did not cause your depression. Your belief about her actions is what's causing your depression. Most of us really don't want to hear it, especially when you're depressed, sad, feeling, wronged. It's very, it's not fun to explore that. But once you begin to really buy into this idea that, there is this event, and it's our beliefs about it, our assumptions about how things should be different, is what's causing our suffering, not the event itself. And when you truly get that insight, it really changes your whole life. It's quite profound. It really changes how you engage all aspects of your life. And so, although this seems very simplistic, and often you can put it up on a cute little board, and you can diagram it out, but I think there's another layer here that is a very profound insight in life, and that can really change how one relates to all of life. And so this whole idea that whatever symptom we're experiencing is not due to a set of life circumstances, but our beliefs about those life circumstances, which generally, in a nutshell, are things shouldn't be that way, and yet they are. And so if you can revise your belief you will have different consequences. So, so this is, I think, a really profound idea that's really the underpinnings of the cognitive piece of this approach. And that when this really sinks in, it's a very profound insight. And I also think it's important to be careful to not take this in a direction, because it can have undertones of blaming, the victim, blaming the client. You're the one creating your own depression. Stop, believing that. And then so that's also the wrong way to work with these ideas. And you have to be careful that you don't have to engage or, present these ideas to clients in such a way that they begin to feel blamed. Instead, having a compassionate stance for this is kind of, I think, or at least according to this theory, our default way of engaging life. And the only time we need to sit back and examine those beliefs is when we're having undesirable, symptoms, sadness, or, becoming angry or rageful or whatever it might be. That's when we need to go and examine these beliefs. But it is something to do, and it's important to do this whole process in a way that doesn't belittle or blame the client for whatever might be going on. So now I want to talk about the big picture and looking at an overview of the counseling process in CBT. So if you look at the 4 basic steps or phases of CBT, the first one is assessment. And so whether it's more behavioral or cognitive, so if it's behavioral assessment, and we're going to talk about case conceptualization in a moment here, you'll be, analyzing, what comes before or after the symptom, what's reinforcing the symptoms or the problems. In a cognitive approach, you'd be focusing more on what are the beliefs or schemas that are creating the problems. So first you assess what's not working, what's not right. And then step 2 is you target specific behaviors or thoughts for change. And so often this targeting is very concrete and specific. And typically the targeting would be, wanting to reduce, the frequency. They might use, frequency count, so no more than, one panic attack or, no panic. The goal is to, not have panic for 3 months and then therapy is over. And so you would, develop these behavioral targets. And I talk more about that in my treatment planning lectures. And, in the book, I go into a lot of detail about how to do that. And in many ways, I guess I should jump in here and say that, the CBT way, particularly the behavioral part of that, the behavioral measure for goals and treatment targets is very much required by insurance payers and such. So it's pretty much the standard approach for writing goals. Although, if you're familiar with my textbooks talk about how to, use all the various, counseling theories, family therapy theories, and to write the goals from the therapeutic perspective and then link it to some of these behavioral targets. That is what the third parties are wanting. So then step 3, you have to educate clients. And what that involves is, setting up a new reinforcement schedule for the desired behaviors and or, finding ways to change the beliefs that are related to the problems. And then finally, step 4 is the replacing and the retraining. So in step 3, you're educating them about how to do this, and then step 4, you are replacing or retraining or doing new pairing of stimuli and such to correct whatever the problem is. So it's a very it has a technical feel. It came out of a laboratory environment, and you can kind of see that very concrete, step-by-step, logical problem solving. So I think a lot of people that kind of naturally default to this because this is a very logical way to solve problems, at least in a Western cultural context. Making connection, developing the therapeutic and counseling relationship in CBT. So as I mentioned earlier, one of the kind of signature elements of the therapeutic relationship in CBT is that the therapist or counselor takes on much more of an educator or expert role. They might go up to a whiteboard and draw the ABC, thing on the board and, analyze the client's particular situation. They would probably do, assign thought records. We'll talk about those in a moment. They'll assign homework tasks. And have clients, go through their week and, analyzing, but teaching them to use tools outside of the session. And so there is this educator and expert role that the therapist takes on. And actually this can work well with diverse clients, especially those who come from cultural backgrounds that kind of see doctors as experts. And they want the doctor to be an expert, actually. And so that can actually be comfortable with certain clients from diverse backgrounds, and we'll talk a little bit more about that at the end of this lecture. But again, you have to be careful because this approach is loaded with a lot of Western cultural assumptions about how to solve problems. Looking at certain, it tends to look at emotionality in a very logical way. So there are a lot of even gender, culture assumptions kind of embedded that one needs to be aware of and careful with when working with, all clients, actually, not just all clients are diverse. Everyone's got, gender, culture, ethnicity, and so all of that is important to consider. And as I mentioned, increasingly their empathy is used on the part of the therapist. Often, though, it's used very differently than empathy is used in humanism. In a humanistic approach, the therapist uses empathy as a curative, for lack of a better word. It is the therapy. It is the intervention. It is what's going to promote change. It's curative. It's what's doing the therapy. What's doing what's promoting the change that is desired. In CBT, empathy is used to build rapport, to make clients feel comfortable, to make clients feel understood, so that they trust the therapist and it allows them to then be open to the education portion of it, which is where they would say the real change comes from. So it's very different. It's used to build connection so that the therapy can happen. Whereas in humanism, the empathy is the process for creating the change, the desired change. And so the more contemporary CBT alliance it tends to be more egalitarian, tends to have more warmth in it than the traditional, more the lab coat therapist. But that's the culture that this evolved out of. And so it's very natural that would be the relationship where this began. And I think even within Western culture, there has been a flattening of hierarchies in many ways. And so this kind of demand for more egalitarian, more warmth, caring, is just also, CBT is evolving as the culture changes. Another unique thing about CBT is that many CBT therapists will actually use written contracts for how long the therapy will be, how frequent they will meet, what the goals are. What the clients are writing these contracts out, and what interventions, and the clients agreeing to do the homework and such. And so they make it a very formal relationship in that sense. And so these contracts are used to help motivate clients to be engaged in the process, which often can demand quite a bit of outside homework and work, compared to other approaches where, humanism and or psychodynamic, where most of the transformational process is in the session. So let's next move on to talk about case conceptualization in CBT. So there are actually many ways to do case conceptualization, and really the distinction between most schools of CBT would be in how precisely they engage case conceptualization. And so we're going to cover these main ones. There are more out there, but these are some of the main ones that you will see across the various specific approaches. So looking at baseline functioning, it's a behavioral approach. Looking at the functional analysis which has a strong behavioral element to it. Analyzing or identifying schemas and core beliefs. Identifying distorted cognitions. Looking at identifying irrational beliefs. Looking at the negative cognitive triad. There is a whole system called the basic id for multimodal therapy. And we'll also talk a bit here about DSM Diagnosis. So one form of assessment would be doing a baseline functioning. And so this creates, this is where you get a baseline. So how frequent is the behavior? How long is it? What is the severity of it? And often identifying any antecedents, so events that may have triggered the symptoms as well as the consequences. And so, for example, and this can be very useful because most of our eyewitness testimony and memory is not so good. So it's very helpful to ask clients to actually write, even if it's, for just a week, to write down, to get a baseline functioning. So that what that would mean, for example, if a parent is reporting that a child is having tantrums, you would have the parent go home and keep a record of how often, were the tantrums, how long do they last, how severe was each, and to notice any antecedents and consequences from this. And that can be very useful because often, especially when parents in tantrums, they can either overestimate or underestimate. Same thing with conflict with couples. And even things like depression and panic. It's very interesting. I find you can be very useful to actually get a baseline of depression because most people come in saying, "Oh, I'm feeling depressed, and it's been like this for weeks or months." And oftentimes, though, to get a baseline in terms of when are the depression symptoms most prominent, because many people I've worked with, when they go to work, that they almost disappear or significantly less severe at work. And then they're more severe in the morning and or at night when there's free time. So that's a common pattern. Some people are more depressed at work too. So it's useful to just get a sense of, and I think it's very enlightening to actually, especially with depression, I like for them to rate, on a scale, I give it a scale of 1 to 10, and to see how it ebbs and flows across the week and across the days even. In the morning it could be the worst, or it's not too bad and it gets worse. I think it's very eye-opening for many people and opens up some new ways of looking at what's going on by getting this baseline functioning. So a similar but more elaborate version of baseline functioning is getting a cognitive behavioral functional analysis. So a functional analysis goes a bit deeper than baseline, and it involves a much more careful analysis of the antecedents and consequences of problem thoughts and or behaviors, because you can have a person look at what they are doing and thinking, and what was going on in the environment before the symptom, and then what happened afterwards. And so that is a lot more detailed in terms of analyzing multiple layers around an occurrence of the symptoms. So this is another assessment option when working from a CBT perspective. And again, you would depend on what the problem is, whether you would do more of a baseline or a functional analysis. You can obviously do both. One's almost an extension of the other. For example, with childhood, very concrete behaviors, often a baseline is sufficient, especially with child behaviors. With younger children in particular, not so much. The teens, you might want to do more of the functional analysis, a little more complex. It adds in often the psychological piece. And so if there's more psychological elements to it, you would probably want to add this functional CBT analysis. So another approach to assessment from a cognitive approach is assessing schemas and core beliefs. And this comes out of the original work of Aaron Beck, who talked about we have these automatic thoughts, kind of like these knee-jerk reactions to a distressing situation. So, we were talking about the girlfriend breaks up with me, and that's not fair, that's wrong, this is terrible, this is horrible. So that's the first layer. There's intermediate beliefs that are kind of between these automatic beliefs and the lower levels of core beliefs and schemas. And so the more intermediate belief is that it's breakups are bad. And then you can go down to this one level deeper is kind of core beliefs. These are more global, but often very absolutist. And they're usually about ourselves, such as I'm worthless, I'm not good enough, I'm a bad person somehow. And so this breakup could be triggering, I'll never be good enough, I'm not good enough for anyone, no one will ever love me. And then schemas are the deepest level in this cognitive approach of Beck, which is, it's a very fundamental kind of cognitive framework that really organizes and shapes many thoughts, feelings, and behaviors. And so this is when you get into, again, the, I am fundamentally worthless, I'm unlovable, no one will ever love me, but very core schemas that kind of color a lot of how we see life. And so the assessment process or conceptualization process is going to be identifying the core beliefs and or schemas that are underlying the symptoms. So in this case, breakup, results in a depressed mood. And so you're going to look at the core beliefs and schemas that were triggered, that the breakup triggered, your beliefs about that and what you believe that says about you, life, your future, your values, what life is about. So anyway, this is the a way of cognitively assessing what's going on, and then those become targeted for treatment and for change. So another cognitive conceptualization approach is to identify distorted cognitions. And cognitive therapists have, this is a list by Aaron Beck of the types or common forms of cognitive distortions that we all like to indulge in that often create anxiety, depression, inspire, eating disorders or substance use disorders. So, so these are some of the common things, such as magnification or minimization. So magnifying certain, focusing on certain things and exaggerating it in our minds, or minimizing in our minds. Personalization. So you're personalizing, maybe your partner just doesn't like country music, and you take it as a very personal statement about your partner not liking you. And so, because you like country music. And so that's, so they're looking for these habits of mind that we all indulge in to a certain degree to, and they start identifying these to help identify the underlying core beliefs and schemas. So these are habits that tend to be pretty readily identified. I would say this is some of the first cognitive stuff you will notice as people talk. Albert Ellis talks about identifying irrational beliefs, and he identified the 3 basic musts. And he views irrational beliefs are typically flagged by words such as should, ought to, must, I must do these things. So, and he talked about 3 basic categories. And again, this can be as a way, as you're listening to clients talk about their problems, you can listen for these themes. So one is perfection-based worth. Like if I don't, if I'm not perfect at work and recognized at work, or always at the top at work or at school or my, relationships, if I'm not perfect, if everything's not going right, I'm worthless. And so this is very common in Western culture in particular, to have your self-worth based on your achievements. And that normally is not a very stable way to develop your identity, and you're likely to experience either anxiety or depression when you are unable to sustain, a level of perfect, performance. Another one, if you don't know Ellis, he is a bit on the snarky side. So justice for me. And so this is one where you kind of have the assumption that everyone on the planet needs to be nice to me and appropriate with me all the time. No one else can have a bad day when they're interacting with me, and everything should always be fair for me. And so this is another really common one you will see. Again, it's one very common in Western culture, in the sense of, life should always be fair, and when it's not, I'm going to get angry and frustrated and or sad and depressed because I wasn't treated correctly. And then the third one here is effortless perfection. This is the belief, comes from the belief that things in life should come easily. Like you shouldn't have to work that hard to have all the good things in life. And so when things aren't going well or easily, it feels like there's a problem. So again, these are very common beliefs, and Ellis has kind of categorized this to make the assessment easier. The negative cognitive triad was developed by Beck in observing clients who come in with depression. And so basically he said that they tend to have these negative thoughts in three areas. Negative thoughts about the self, I'm worthless, I'm not good enough. Negative thoughts about the world or life, life is unfair, people aren't, no one treats me right. And then negative thoughts about the future, things will never get better, this is not going to end. And when you have this nice combination, you tend to, it's the recipe for depression within his cognitive theory. So if you're working with someone who's presenting with depression, you would want to assess these three areas. So multimodal therapy is a particular CBT approach, and its particular assessment includes looking at all these different layers of functioning. So you'd look at their behaviors, their affect and mood, sensations, so physical, sensory stuff, what's going on, imagery, if there's images in their minds that are problems or in their dreams, cognition is thoughts, interpersonal relationships, and then drugs and biology, so what might be going on. So they use these various areas, they would assess all of these areas and the person's functioning in these areas, and then determine where to intervene based on that. And so it's a very global assessment, across all various areas of functioning. And so that makes it a very client-focused approach, and they try to fit the treatment to the client. So it might be more behavioral if that's where their problems are. It might be more cognitive. They might address, the drugs or biology issues, or it might be more relationally focused. And so they assess across all these and then customize the treatment based on that. So of all the psychotherapies and counseling models, CBT is most closely aligned with the diagnostic DSM manual, and it's very closely aligned with the medical model. And so CBT conceptualizes within it, you identify the syndrome, the DSM diagnosis, and you develop treatment around that. And so naturally, most of the evidence-based treatments, which are treatments designed for a specific problem, many of them are CBT based because that is how the theory works. And so for example, Beck has developed several specific cognitive approaches for working with depression, then anxiety, eating disorders, substance abuse. So they develop, it's very consistent within the approach to be developing almost like protocols for the various presenting problems. And this is why it's kind of the preferred model. It speaks the medical language, and so it tends to be the preferred model by third-party payers. Because if you're accepting a whole bunch of, you need to pay doctors and therapists and counselors, you want to use a very similar system for managing all that paperwork. And so in many ways, this naturally fits in with what the rest of the healthcare industry is doing. So now let's talk about setting goals in CBT. So in many ways, the goal-setting approach in CBT is kind of preferred by third-party payers, and often the form that is required, for example, in a government or county agency setting. And you will see lots of examples in my in my books about writing treatment plans, especially in the Theory and Treatment Planning book, as well as the Case Documentation book. And so the CBT fits most naturally into this. And I think, as I mentioned earlier in this lecture, my book will go through and also show you how to take psychodynamic ideas and make them fit, into the language that third-party payers require while retaining the thinking of psychodynamic or postmodern or family systems, retaining the logic of those intervention approaches. So the goals are typically symptom and problem focused, and basically reducing the symptom or the problem. More so than increasing. Often they may use increasing language, but it's often a emphasis on decreasing something, such as decreasing depressed mood, decreasing anxiety. It is based on also that the goals need to be behavioral and measurable. And again, this comes very much out of their scientific tradition that these approaches grew out of, that you need to be able to find a behavioral way. How do you know that we've achieved our goal? So, there has only been one mild episode of depression, in a month. And so, or whatever it might be. No more than, one mild, panic episode rather than, and no panic attacks for a month, maybe the goal, or whatever it might be. So again, you need to and often clients are involved in discussing and setting these goals. So now we're going to move on to talking about interventions, and there are a lot in CBT. They love interventions, and they do really concrete interventions, compared to more process-oriented approaches. So this really list is endless, and so we're going to touch on some of the more classic ones. So one of the most common interventions is psychoeducation in CBT, and it's actually hard to do this well. Because the goal, it's easy as a therapist to get in there and just start talking about, cognitions or behavioral this or that and the other. And as you do this, you typically will give the clients far more information than they could possibly soak in and use to make a change in their life. And so my little rule typically is, about 2 minutes of psychoed and then 48 minutes of how do you apply this in your life. And that's about the right recipe I have found for managing, or for doing psychoeducation. And in my book, I go into a nice long list of how to kind of move through this to help to use psychoeducation effectively. And clients often enjoy learning things, but then applying it and using it to actually, address the issue is a whole different skill set. And so you're going to keep it brief and then, break it down, get the clients buy-in maybe is one way to look at it, or, what their thoughts are. Do they think this is going to work? Are they willing to try it? And then how would this look? And then problem shooting, what are the problems that are likely to happen during the week? And so it's a very involved process, and it's tempting to give way too more information that could be used. The Socratic method, or guided discovery, is used a lot in CBT. And so this is where, rather than telling a client that you're having an irrational thought or that's dysfunctional thinking, you use questions to allow them to discover for themselves that what they're thinking is not that logical. So, things like, what evidence do you have to support your belief? Is there any evidence maybe to the contrary? Might there be, or do you think there's a more realistic middle ground? What does person so-and-so say about your situation? What is the realistic likelihood that these things would really go so badly, and that these are likely to have? So you use this kind of Socratic method, so the client is the one who begins to realize how their thinking and beliefs may not be all that realistic, and thereby reducing the effect that they're having in their lives, the problems. A more concrete way of addressing kind of dysfunctional thinking is the thought record. And what this is, you would have them maybe hear what you're going to do, and there are many variations on this, on a piece of paper. You'd probably start on a whiteboard in the therapy room, and have them do this as homework typically once you've done it a few times in the room. You'd have them identify a situation, behaviorally, maybe there was a stressful situation at work. Then you identify what were the automatic thoughts. My boss hates me, because he, cut me off in the middle of a meeting. And then what were your emotions? So you might identify the emotions around that. I felt angry, I felt humiliated, I felt shamed. You could, so what did that lead to? Well, I ate an extra candy bar and I was short. I avoided him the rest of the day. I didn't talk to anyone else for the rest of the day at the office. I didn't get good work done. And so then it might have them identify what's a more adaptive or reasonable, what are some other interpretations for why I got cut off in that meeting, and, what would be a more realistic belief to have in all of this. And so similarly, a similar process is facilitated in, the various schools of CBT can have different forms in terms of, there's a rational emotive therapist, have the REBT self-help form, which again, they identify the activating event, the irrational beliefs, and then they have them dispute those irrational beliefs and identify more realistic beliefs. And there are examples of these in the book. There is also labeling cognitions, and so identifying that you're personalizing, minimizing. So once you've assessed those that we talked about early, or the distorted cognition patterns, then you would teach clients about what personalizing and minimizing, magnifying, mind reading, catastrophic thinking. So you would have the clients learn to identify and then replace those with more realistic beliefs. There's also problem solving and coping skills training. So there's often this would be done in a group format. It could be done in a one-on-one format too, where you teach them to, how to step-by-step, solve problems, develop coping skills. So teaching them various skills to calm themselves down. In many ways, the whole mindfulness-based treatments are all a very specific coping skill that's being taught in those. It's more than a coping skill, but it's the same idea. Having clients identify negative inner talk and changing that negative self-talk, and that's through something often called stress inoculation training. So that means if a stressful event is coming, you have a stressful exam coming up, you would have the client rehearse positive self-talk to not have so much anxiety related to the exam. Of course, here the list continues, and like I said, it is truly endless. But cost-benefit analysis, so what are the pros and cons of a particular different courses of action? There's still classical conditioning, where you pair a relaxation response with a stressful situation or some variation of that. There's still operant conditioning and reinforcement, so this is Skinner's cats, where you're going to reinforce, steps and behaviors that go in the direction of the desired behavior. There's systematic desensitization, typically used more for phobias and anxieties, where you systematically, have the person, exposed to maybe a picture of a spider, and a spider in the far corner of the room, middle of the room, hold a spider. In vivo exposure and flooding is used for certain phobias, and fears may respond well to just flooding, which is like just go in there and, get in, jump in the back deep end of the pool metaphorically or maybe literally, depending on the situation. So that's what flooding is. It's just letting them experience it till they get, and allowing them to become accustomed to it. There's also EMDR, is a very specific form of this eye movement desensitization reprocessing. It's a very specific trauma intervention that you can get certified in. So it goes on with the mindfulness, which I've talked about, which I will talk about in other lectures, is another kind of mindfulness-based intervention that's an option that therapists may use or assign. So it goes on forever in CBT, but these are some of the standard interventions in the field. And like I said in my book, I have examples of what some of these forms would actually look like, because they're one of the few therapy models that have forms and handouts that go home with clients and such. And so next we're going to talk about research and the evidence base related to CBT. So, as I've mentioned throughout this lecture, that research is very much part of the culture foundational assumptions of CBT. CBT grew out of the laboratory environment. And so when you go and read the National Institute of Mental Health, they have a list of evidence-based treatments. CBT dominates it. It really does, because that is the therapeutic model that grew out of, the scientific method. So you will see there are lots of different, the list it goes on forever. I have a nice long list, I think, in the book too. But, integrated behavioral couples therapy, trauma-focused CBT, cognitive behavioral for panic, for generalized anxiety, for depression, the list is quite long. So there are many such things that you will find. So the evidence base is strong for CBT. And finally, I want to wrap up by talking a little bit about using CBT with diverse populations. So CBT has been used successfully with a wide range of diverse populations and has been even studied with some of these populations. And the thing to remember, though, when working with culturally diverse clients is that you want to be careful in terms of looking at some of the embedded values that are part of CBT. CBT, very much embodies the Western, scientific method, and it really privileges a very linear type of logic, which is really not the only logic on the planet, and because there's more emotional forms of logic, and it has within it also a very individual, it kind of privileges a very individualistic set of values versus communal values, and a lot of what may be logical and or dysfunctional thinking. You need to consider what you're going to label irrational or dysfunctional thinking in terms of the client's cultural and religious, even social economic class. And so the idea here is just to be cautious and mindful of that, and to be mindful of the values and assumptions that are embedded in the approach. That said, as I think I mentioned earlier, many diverse populations do want to view their counselor, psychotherapist, social worker, psychologist, psychiatrist as an expert. And this particular approach, encourages that stance. And so there are many diverse clients who are comfortable with that relationship and how they structure the relationship and the educational piece to this. And again, it's just being mindful in terms of how you apply it. So finally, I also want to talk a little bit about working with LGBTQ clients using CBT approach. And the first thing to be mindful of here is that therapists want to begin by looking at their own core beliefs and schemas related to sexual orientation and gender identity before working and trying to use these ideas with diverse clients. And one of the things, too, there are several various models you can look at in terms of working with LGBTQ clients using CBT. And so you want to look at identifying some of, there are even some lists of some common irrational beliefs of clients, especially those who've experienced marginalization, discrimination, and how that can often kind of magnify some of the any core beliefs or schemas a person might have about, for example, let's say their worth as a person, and having repeated episodes of discrimination and harassment certainly are going to magnify and intensify those. And so also look at examining the role that social norms play and even stigma play in the development of the client's beliefs and schemas, and working with them to find ways to develop more realistic, more fair evaluations of themselves, life, others, and in a way that helps them to kind of cope with what will be most likely ongoing discrimination in their life and various forms of marginalization. And so there is both, extra work that needs to be done, because of the discrimination typically experienced, as well as extra work in developing extraordinary coping skills often to cope with it, to cope with what's going to be an ongoing stressor of being different in their life. So, okay, so that was introductory kind of whirlwind tour of sorts of cognitive behavioral therapy. Again, I have other lectures that relate to dialectical behavioral therapy specifically, and trauma-focused CBT and mindfulness. Like I said, it is a very CBT is a very broad class of theories, although they do share some very basic, common, core underpinnings and assumptions. And it's a widely used model, and I encourage you to read far and wide. And I hope you found this lecture very useful and helpful in your introduction to CBT.